My name is Brett Burstein, Pediatric Emergency Medicine Physician at the Montreal Children's Hospital and Associate Professor of Pediatrics at McGill University. And on behalf of my study colleagues, I'm pleased to present the results of our study entitled Optimizing Management of Febrile Young Infants Without Serum Procalcitonin. Febrile young infants are frequently evaluated in the emergency department. In this population, fever is often the only sign of invasive bacterial infections, or IBIs, specifically bacteremia and bacterial meningitis, which, if undetected, could result in serious complications or death. Historically, management has involved lumbar puncture, hospitalization, and empiric antibiotics to avoid missing IBIs. Clinical practice guidelines from the AAP recommend procalcitonin testing to assess risk of IBI, but that when procalcitonin is unavailable, the inflammatory marker combination of C-reactive protein, absolute neutrophil count, and temperature should be used. However, prior to this guideline, no study had previously evaluated these inflammatory markers together. We sought to statistically derive and internally validate a clinical decision rule using AAP-recommended inflammatory markers for when procalcitonin is unavailable, prioritizing not missing IBIs while maximizing test specificity. We used prospectively collected data from a tertiary pediatric ED between 2018 and 2023. Clinically, all febrile infants 60 days or less had blood and urine cultures collected, standardized inflammatory marker testing, and telephone follow-up at 14 days post-discharge to ascertain for any missed IBIs. For this analysis, we included all infants aged 8 to 60 days with rectal temperatures of 38.0 Celsius or greater that were previously healthy, term-born, well-appearing, and meeting AAP inclusion criteria. We derived a decision rule using classification and regression tree analysis, or CART, applying a 100-to-1 penalty for missing an IBI, followed by tenfold cross-validation. We compared the diagnostic accuracy of the derived rule to the AAP recommended strategy and report here their negative predictive value, sensitivity, and specificity. In total, 1,987 infants were included for analysis, among whom 38 had IBIs. For best diagnostic accuracy, CART analysis identified optimal thresholds of less than or equal to CRP of 22.2, maximal temperature of 39.0, and ANC of 4,500. Infants with a CRP of 22.2 or less and a temperature at or below 39.0 were low risk for IBI. However, infants with temperatures above 39.0 remained low risk if they had an ANC of 4,500 or less. The derived rule correctly classified 1,633 infants as low risk with no missed cases of IBI. The derived rule had perfect sensitivity and negative predictive value for ruling out IBIs with a specificity of 83.8%. On tenfold cross-validation, high sensitivity and negative predictive value were maintained with nearly identical specificity. Moreover, using a simplified rule with all three markers below thresholds had a specificity of 63.4%, which was still significantly higher than the AAP recommended strategy with a specificity just over 50%. This study has limitations. This was a single-center study at a tertiary pediatric hospital, and results may not be generalizable to other settings. We did not assess fever or inflammatory marker timing, which could impact the diagnostic accuracy reported here. Though we internally validated the rule, external validation in a large multi-center cohort with more IBIs would give better estimates of precision. However, if externally validated, the derived rule could allow for more accurate prediction of IBI risk and further reduce unnecessary procedures and treatments for more low-risk febrile young infants.